Hi everyone, I have been so busy. I've been slacking on these rotation recaps, so I have to do NICU and surgery today. I did my surgery rotation most recently for my October rotation, and I did my NICU rotation in September. So let's start with NICU, and if you want to fast forward to surgery, you can do that. Where do I start? I definitely recommend doing a NICU rotation if you're even thinking about it. It was awesome. I learned a lot. I love working with babies. Downside is I didn't get to cuddle as many babies as I wanted to because we do rounds on them really quickly and do lots and lots of procedures on them, which I'll go into. So starting with the schedule, I went to work at around 8 a.m. every day and finished around 4-ish, give or take. Sometimes I stayed later if there was a interesting case. Sometimes I left earlier if there was nothing that was going on. And yeah, I really loved the PAs that I worked with. Of course, I always say the preceptors really make or break your rotation. So thankfully I had awesome preceptors. Not only the PAs that I worked with, the labor and delivery not the labor and delivery doctor. The doctors that are part of the NICU that go down during deliveries, as well as some other physicians that were around that really taught me a lot. So, like I said, we round in the patients. My PAs had anywhere from 10 to 15 patients. They said this is a busier time. Usually they have less. So we round on those patients, put in any of their TPN, like their feeding orders, which I had to learn how to do all the calculations for that. So you could look that up if you want to get a head start. And we also did lots of procedures, and it really impressed me how much of the procedures were done by the PAs, including the lumbar punctures, intubation sometimes, and I'm missing, central lines or like umbilical lines. Super cool. The umbilical cord does not have any nerve endings. It doesn't cause them any pain. Any critical patient or baby that's born, we put in some umbilical lines, and then we also can actually do it on the babies after a few days even if their umbilical cord is slightly starting to dry, we can still try to put lines in that way. Super cool. That reminds me, things that you can go over before your rotation that I didn't do myself and you get quizzed on are things like the different heart malformations, like whether they're cyanotic or non-cyanotic, and all of the different trisomies that are common. We saw lots of different patients with various disorders. You can also definitely go over the fetal heart circulation. That's a big one. Look up how to do an umbilical line, lumbar puncture, all that good stuff. So there's umbilical arterial line and venous lines. So both of those, and different, I was gonna say milestones. That's not really accurate. Yeah, okay. Drawing a blank. I love the rotation. Highly recommend it. You should do it. I could definitely see myself working in NICU, but I say that about a lot of things as long as rotation goes well, and I love the people around me. I feel like a lot of different environments you can thrive in and learn in, and again, like I said, it's pretty freaking awesome how much autonomy and how much capabilities the PAs have in the NICU. All right, if I remember something, I might chime in on it later, but we will move on to surgery. Actually, let's back up. The other things, we went down on deliveries a lot, which was for various things. If there was a baby that was born to a diabetic mother, and you should look up the different complications that happened there. I didn't realize they were very poor feeders. We had one baby that was had to get a feeding tube, like a G-tube placed, just because baby had nothing wrong with him except that they, weren't really feeding, and a lot of complications from having a diabetic mother, as well as meconium aspiration issues. If there's meconium in the delivery, we automatically go down, and then I didn't realize how bad meconium aspiration syndrome can be. We also learned about, it's been so long now, I'm forgetting everything. I have it at the tip of my tongue, and I can't remember it. The necrotizing, okay, I'm gonna have to skip this because I forget, but lots and lots of things. Maybe I'll put it in the comments if I remember different things that you can look up that like we saw constantly. Oh, a big one is man, I'm blanking on all the names of it. The neonatal abstinence syndrome after baby's been born with, you know, to a mom that had an addiction of some sorts. So clearly my mind is blanking too much, so we're gonna skip to surgery, which I ended up enjoying way more than I expected. Of course, again, in part to my preceptors that I enjoyed, and I love hands-on things, and it's a lot of fun. So starting with my schedule, that is the only downside. You wake up at the crack of dawn. I was up at 5 almost every day. At the hospital between 6 and 6:30, depending on we have to go early to round on patients. So sometimes we'll round before surgeries, and other times we just need to be scrubbed in before surgery, get your supplies, and be ready to go before 7. So definitely an early start. And most days we would then go to clinic from 1 to 4. So most days were like 10-hour days, but it kind of broke things up that the first half of the day was surgery, second half was clinic, kind of kept things new and exciting. We did a lot of robotic surgeries, which was super cool to see. It allowed me to see more than just, well, it depends, because sometimes there's multiple people, residents and med students in the room, and unless you're the one scrubbed in with an open case, you can't really see much. So it's awesome when it's a robotic procedure and you can see everything on the screens. You really get to learn a lot that way. So we did some open cases only on a rare occasion when they're really needed. Otherwise, we did robotic cases, lots of cholecystectomies, so gallbladder removals, colon resection, sigmoid resections for like diverticulitis or cancers, and appendicitis, so appendectomies, everything in the abdomen region. Oh, umbilical and inguinal hernia repairs, lots and lots of those. So lots of things to look over in terms of anatomy. Definitely review your anatomy, know the difference between indirect and direct inguinal hernias, know what the critical view is of the gallbladder, know the duct system, of course, the arteries around there. Even the anatomy when you're looking down the pelvis, the pubic bone, the bladder, all of that good stuff is good in case they ask you questions about that. Some other tips that I found important just in terms of surgery, hospital etiquette that I didn't know about. Well, one, my preceptor told me where all of the supplies were and to make sure I brought my own gloves and gown to every surgery and have that ready in the morning and introduce myself and write my name on the board. Do not open and drop any of your sterile items onto the sterile field unless you are given permission to do so. Definitely go over how to scrub in and, more importantly, how to gown and glove. Maybe I'll make a video on that. I was given some gear to do that. We shall see. But the biggest thing for gloving is that they open the glove for you to put in your first hand, and then once this hand is gloved, you're going to open the other glove with them to put the second hand in. Look up a video, it'll make more sense then. You scrub it initially, like with a full scrub, and then we always do, I'm not gonna remember the terminology for it, but it's not sanitizer, but it's like a sanitizer that's a scrub, and we put that on in between cases. So that's helpful. You don't have to scrub in every single time. Otherwise, I'm sure I would contaminate something. Make sure to bring goggles of your own, or you can borrow the ones there. Anyways, backtracking, yeah, make sure you bring all your supplies. You're nice to everyone. Even if they're not nice back, just kill them with kindness and they'll get used to you. They're not gonna remember your glove size, so make sure you bring those, like I said, because they have a lot of students to deal with. Another thing that I did not know was there's this red line in ORs, and you're not supposed to step over the red line without a hairnet or a scrub cap or whatever. I was definitely yelled at twice for doing that, and now I know. So look for that red line and don't go over it unless you have your scrub cap and your mask on. And you're supposed to be in their scrubs, you know, no street clothes. So that was a big tip. What else? So definitely anatomy, going over those procedures. Oh, eat when you can, and try not to drink too many liquids because, you know, I definitely drink plenty of water and coffee and would like to go to the bathroom often, but you can't. So yeah, and take advantage of eating any chance that you get. If they walk with you to get snacks and you're not hungry, just eat them because you don't know when the next time you're gonna eat it. My favorite snack to bring is those peanut butter pretzels, like the stuffed pretzels from Trader Joe's, because there's something that have, you know, that will stick by you and you can just pop a few in your mouth any chance you get. Sometimes I would put a granola bar or those in my pocket so that I had them available if we get any downtime. And yeah, don't be scared. You'll be fine. Don't be afraid to get close to the patient. If you're sterile, you can put your hands on the patient. That way, you know, you don't break sterile field. Make sure your back doesn't hit anything. And yeah, it'll be good. Oh, of course, go over suturing. We mostly did a deep dermal suture, which maybe I can make a video on that too, but look that up. And yeah, you'll be great. Don't be scared. It's fun. I think it's fun and you'll learn a lot. So there was my recap on my last rotation ever. I cannot believe it. It still hasn't sunk in yet. We have I have my EOR tomorrow for surgery and some pants boot camp and then graduation in like 7, 8, 9 days. Holy smokes. Thanks for tuning in and sticking with me. Subscribe below, like, comment, share. Talk to you soon.